And the topic today is really how to prevent patient termination and the insurance company cutting your bill, or the IME stopping the patient from getting care and cutting your bill. So, in other words, how to stop getting a letter from this. This is an IME letter um, that a patient of a chiropractor was sent to this IME doctor. And these are the basic questions. These are the basic questions that the insurance company is going to ask of your notes, and whether or not you have the documentation to support your notes. So again, the topic is how to support your case, not only for treatment, but for services, and not have your bill cut by the IME doctor. So this gives you the insight of pretty much what you need to combat. So these are the questions the insurance company is going to ask. So if you don't have the right information or the correct information, then you will in all likelihood have the care stopped or your bill cut. So it says, and these are boilerplate questions from the IME. And so what you're looking at here, it says specific question arisen: is the provided treatment related to the injury or condition diagnosed and documented in the clinical records? So they're looking to substantiate, is the treatment related to the injury? So you want to obviously be making sure in your note, and we're going to cover how to do this, but obviously you're going to want to make sure that your treatment is specific to the injury. Based on your review of the records, your clinician experiences, and applicable research, was the claimant's condition caused? And that's what we talked about, having a direct correlation between the in your notes, a direct correlation, and that's taking a good history. When you take a good history, we'll see the direct correlation. You're substantiating the direct correlation between the accident and the injury and the signs and symptoms. And then number 3, it says, are the type, intensity, and frequency and duration of the provided treatment or services or products consistent with acceptable medical standards, appropriate for the severity of the documented injury or condition? So the frequency of and the type of condition, so we'll talk about that. So the question here is the type, intensity, and frequency of duration or treatment of product consistent with medical standards? And again, what are you doing to document that is the case? And we'll cover that. And was the usage or timing of the diagnostic test consistent with acceptable medical standards? And the timing of the test. So that's important too. And then we come down to number 5, says, was the provided treatment necessary for the patient to achieve maximum medical improvement for the documented injury? And of course, that's the goal, is MMI, maximum medical improvement, pre-injury status, or when they plateau, then that's it. Well, they would not warrant any further care, and there'd probably be a settlement in the case. Is the current or recommended future treatment plan appropriate for and consistent with the severity of the patient's condition? So these are the questions that you're going to need and want to have answered with your history, your consultation, your report, your SOAP notes. And so let's talk about how to substantiate care and the major components to substantiate care, and make sure you have all of these documented to prevent your patient from having an IME doctor either stop the services or stop your the treatment, or stop your services in your billing, or even throw out your billing. So number 1 is, in the history, is making sure we talked about having a direct correlation. In a different video we covered in specific detail having a direct correlation between the cause of the injury. So making sure that you're looking for, in the consultation, making sure that you're interrogating the patient specifically to the mechanism of injury. So we listed a whole list of factors, ranging from where from the accident report to the position of the patient, to the how fast the car was moving, to did they have their seatbelt on, was there any undue influences, were they drinking, things like that. What did they impact first, second, or third? The conditions of the road, so the speed of the vehicles, the mass of the vehicles. So all of those factors we want to make sure that we're looking into in the consultation to have a direct correlation. And then also I talked about, not only the tissue, what they were impacting, but the type of material that they were impacting will have an impact on the injury. And also, was the joint locked out upon impact? Because remember, your body goes through active range of motion, passive range of motion, paraphysiological joint space, anatomical failure. So if it's already at overpressure when the impact occurs, there's going to be even a higher likelihood of anatomical failure. That energy is going to go in the anatomical failure, as opposed to active range of motion. If they had to go through a lot of active range of motion first, that energy will be absorbed and diminish the impact. So anyway, having said that, so that's the mechanism of injury. And remember the 4 components that we're looking to do within the case management. And we're going to get into some specifics. Is number 1, the 4 pillars of case management is the cause and effect relationship. Number 2 is the objectification of the injury. We talked about the 4 major injuries, and being familiar with how to objectify those injuries. And the 4 major injuries being A, the soft tissue injury, which occurs 87% of the time, the majority of the time. And then we talked about the disc injury. So let's go into those briefly and then kind of move on to these categories because of documentation and support. So when we're talking about the ALMSI or the spinal injury, of course, we want to take static x-rays, but also dynamic x-rays. And I'm surprised how many doctors do not take motion studies. And a motion study, I'm not talking about video fluoroscopy. I'm just talking about take a flexion view, shoot the picture, taking an extension view, shoot the picture. That's a motion study, flexion extension. In the lower back, you could do flexion extension. I like to do left and right lateral bending to look at coupling. Intervertebral coupling is what I like to look at. So I like to look at left and right lateral bending. It was much more visually descriptive than a flexion extension low back view. Although if you were looking for translation, you'd want to do that. So that's the making sure you're taking the stationary pictures as well as the motion pictures. And I tell you that those motion pictures are going to be very important for substantiating care, and they're probably going to be your single best indicator out of all the biomarkers to continually substantiate care. And we'll talk about the importance and relevance of the biomarkers, and some of the biomarkers, fade away real quick. And if you don't have a positive biomarker, then there's really no need for care if you don't have that biomarker. So you've got to make sure you know which biomarkers you want to make sure you get, and which ones are probably going to give you the most definitive results or the long-term results for your treatment plan and supporting what you're doing. And a classic example is active range of motion. That's typically a really bad biomarker. It'll have some restrictions in the beginning, but very quickly, active range of motion, especially in the first re-exam, routinely in a chiropractic office patient, a typical patient, goes back to normal. So if you're only looking at active range of motion as a biomarker, not the passive range of motion or paraphysiological joint space, you're totally going to miss out on the substantiation and the need for care in that one particular case. So we're talking about the 4 parameters, and really we're talking about substantiating your case, how to prevent that IME from stopping your care and cutting your bill. So to substantiate your care, you have to have the biomarkers. So there's the signs, the symptoms, and the biomarkers. That's what you have to have. And then from cutting your bill, that has to be substantiated. That's based on the 3 phases of healing. What a standard treatment protocol based on the 3 phases of healing. So you got 2 different animals here. And so you have to be familiar with both. So of the 4 pillars of the personal injury case, it's the substantiating care. Number 2 is the objectification. We talked about the first of the 4 major injuries, objectifying that. The disc injury, the standard protocol for that is the MRI, preferably like a stress MRI. And all you need to do is request it. That's all. Call down there, talk to the radiologist, tell them what you want to do, and have it requested. That's it. And then remember that only happens about 32% of the time. So 2/3 of the time you're not going to have a disc injury. And then and this is based on the Insurance Research Council. And then of course the nerve injury, the peripheral nerve injury, and that's only about 16% of the time. And that has to be substantiated with electrodiagnostic testing. So that's pretty straightforward. And if you've practiced chiropractic any length of time at all, and if you've ordered any type of test, and again, if there's a radiculopathy, I certainly recommend a neurological consult. Refer them to your team member, your neurologist who's on your team, and I talked about how to get a team together for a neurological consult. But if you have any experience in chiropractic and treated patients over time, you are aware that a lot of times patients have referred pain, but they do not have a positive electrodiagnostic test. So you got to be aware of, what's the likelihood of these tests also. So number one, it's only 16%. Number two, they're not very positive on patients who you would routinely think would be that, have referred pain. So that's not a good biomarker either, typically. But if it's there, it's a really good biomarker because it's there and it's true and tried objective proof. And then there's the mild concussion, and you want to make sure that you're having the neurological consult on that also. So those are the 4 major injuries, and so we're talking about the 4. That's number 2 is the objectification of your case. So what are the other biomarkers relative to a classic chiropractic case, a neuromusculoskeletal injury case? And then which ones are gonna be more substantive and show over time, and which ones won't. And then number 2 is what should you be using in your report also to substantiate care and not have your treatment cut and your bill cut. So the classic biomarkers, after you make sure you do a good history with the signs and symptoms that the patients have, specifically with frequency, intensity and frequency, is also what particular activities is restricted or limited or painful. And we always want to go into, and of course you'll get these activities if you're doing the functional capacity indexes. So you'll have some of the restrictions there, and we'll kind of go into that a little bit. So the other common test are your range of motion test. And so what is so important with the range of motion test is to physically put your hand on the patient and move past active range of motion into overpressure. And that's very important to make sure that's documented. And then also, not only have it documented, but you want to grade the pain. You want to grade it a 1, 2, and 3. Is it restricting or limiting it? Can they do it, or can they do the full motion with pain? So you want to make sure you quantify that activity. You not only want to objectify an activity, you want to quantify it. So that's very important because especially in overpressure, remember a lot of times patients will have normal range of motion. If they, let's say they can go back 40 whatever degrees in any particular range of motion, and they can go fully. Well, that's not going to look like a reason for care if their range of motion is fully and you did not go into overpressure, number 1, and number 2, you did not document or quantify any pain associated with it. In other words, they could just go into the range of motion. You didn't take them there any further, and because you didn't take them there any further, they probably don't have any further pain also because you didn't stress that joint. So right there, you lost one of the higher sensitivity biomarkers, because overpressure will be one of the biomarkers that will last a much longer time than active range of motion. So that's kind of a classic scenario. And so not only range of motion, the next one would be your muscle test. And again, there's not many muscle testing, and this is physician muscle test, that cause there's not much weakness. And usually when there's weakness, it's due to pain. It's not due to a neurological deficit. So a lot of times you will not have a good bioindicator with muscle test. It'll be pain based. So you still want to isolate the muscles and test the muscles and do that with the neck. And a lot of times, if they do have pain or discomfort in a particular area, remember when you're isolating the joint, it's in a neutral position. So the joint would not necessarily be in the overpressure position. It'd be in the neutral position, because the goal here is not to test the joint, it's to test the muscles. So if you aren't testing the muscles, then you're going to possibly be losing out there also. But that's typically, you'll find, not a real good biomarker. Likewise, those clean up pretty quickly, the muscle test biomarkers. And so the muscle testing, but you definitely want to do it. And then once again, when you do it, and if there is any weakness in a particular joint, and you will have a lot of times some weakness sometimes in a particular direction where they're having maybe more pain. So that is common, but it's usually not a long-term biomarker. And then you want to do the same thing. You want to quantify the muscle testing on a scale of 5. Where's that patient's muscle testing? So that's not one of the better biomarkers, but you want to make sure you do it. And then, so after range of motion, and then we talked about the range of motion, the nerve testing, how that's done, and the muscle testing. Let me go back to the nerve testing a little bit. According to the guides that it has, the AMA guides, it has to be, the latest guides, it has to be electrodiagnostic testing positive for you to get the impairment rating. But that doesn't mean you wouldn't necessarily. And remember, reflexes and dermatomes are still highly subjective, intra-examiner sensitive. So it's you definitely want to test the dermatomes and the reflexes, but they're, again, not good indicators. You typically, however 20 plus years of practice, I can't think of it, over 5 people that had abnormal reflexes, and then same with the dermatomes. You certainly want to test those, but those are not really good objective tests also, and they're typically not good biomarkers. But in the beginning, they can have some altered sensitivity toward the beginning of care. So it's certainly something you want to do. And remember, anytime you test it, you want to not only test it, you want to quantify it. So you want to make sure you quantify these biomarkers. And we'll get into some of the characteristic biomarkers. And what's the purpose of the biomarkers? The biomarkers are to substantiate care. I mean, you can't just say, I think the person needs care, and see him daily for 5 weeks. And so that's the purpose of the care, is the biomarkers. So you have to know which biomarkers to do, not only to find out what the problem is, but to check the progress of their care, because you want to repeat biomarkers. But it substantiates care. That's the whole purpose of the biomarker, is for those 3 categories. So which biomarkers do you want to pay more attention to and less attention to? And so we talked about the range of motion, we talked about muscle testing, we talked about the nerve, and then the orthopedic testing. And the orthopedic testing typically is the compression tests are the most positive in a typical chiropractic patient, the compression tests that are affecting your joints. So if you're not doing the compression test, you're not going to have that biomarker. But also, what I've found in training a lot of doctors is they do the test wrong. I mean, almost all the new guys coming out of school don't do a good job. And there's 2 reasons they do the test wrong. Number 1 is they're afraid to hurt the patient. Number 2 is they don't have the experience of locking a joint out when they do the test. And that's just experiential. You just get better at your feel for doing tests as you see more and more patients. So typically, when I was training doctors, routinely they would do tests, and the intern would show it's normal, and then I'd do the test, and I'm like, no, it wasn't normal. And the main reason is they were a little too afraid to assert, and they were terrible at locking the joints out appropriately. Remember, each of these tests are very important in the positioning of those joints to isolate particular parts of anatomy. That's the whole purpose of an orthopedic test, is to test as best you can a type of anatomy to see if there's a particular lesion there. That's really what they're about. So be highly aware of that, and when we talk about which tests are the most positive biomarkers that will give you, the long-term need for care, are the compression biomarkers. And now, especially the other one that I actually left out in the range of motion is the last range of motion to clear up is extension. So extension and overpressure is always the last range of motion to clear up, generally in the spine. So knowing that, I want to be highly aware and make sure I'm testing for it and being highly aware of it. So same with the orthopedic test. If I know that that if I don't isolate this joint out properly, that I'm going to have a high likelihood of a negative test. And the most common positive test with the orthopedic testing is foraminal compression in the neck and Kemp's test in the back. Those are the most common biomarkers that will kind of continue on for a longer period of time. In other words, substantiating the need for care. So, and once again, when you do the test, when you do the orthopedic test and it's positive, be sure to quantify it. So grade it a 1, 2, and 3. Does it stop the activity? Is the activity restricted with pain, or can you do the activity fully with pain? So grade it a 1, 2, and 3. You want to not only see if it's positive or not, but also quantify it. This is very important. So that's kind of the orthopedic test. So those are really the 4 big ones when you're looking at a chiropractic exam from the objective standpoint. It's range of motion, it's the nerve testing, it's the muscle testing, it's the range of motion. And then the next one is the x-rays. And let's go ahead and just give an example of a couple x-rays right here. So this is a classic case, an x-ray case right here. And remember, we talked about do not, this is a terrible x-ray because the nameplate is right over the chief complaint area. This is the neck, the chief complaint area. And so this really would reflect bad in a deposition or in court. So this should have been dropped down this way. This x-ray should have been retaken, is what should have happened, so we can actually see the anatomy. So I'm going to look at 2 major categories besides the organic category. And chances are, in chiropractic, if you've practiced any length of time, you're not going to run across a lot of organic types of problems. Chiropractors treat neuromusculoskeletal by and large. And especially if it's from trauma, it's not going to be organic unless there's an underlying pathology, and that's very, very unlikely. Organic pathology I'm referring to. So what we typically will see is structural. So I want to definitely pay attention to the static positions. Like this one, you can easily see the malposition right here of this vertebra right on this vertebra right here. This lateral positioning. And this is the right side, not the left. So this would be a right lateral malposition right there. You can see how it's just tilting abnormal. But again, this is in the way for clarity. So my point is with the x-ray is the static, everybody takes static positions and you want to take the static x-rays. But the motion studies are what are going to be better biomarkers. Dynamic. They're dynamic, and they don't clear up as quickly. That's where you're going to be able to substantiate your care probably the most, is in the motion study x-rays. And so this is the extension view of this particular patient. And again, we're just going to look at the common lines. We're going to look at McNabb's line. If you draw a line, on the inferior vertebra of the low back, have it go back and see if they're actually in the low back for McNabb's line to see if the facet goes on. But the main one is translation and angulation. So translation is George's line. That's the posterior longitudinal ligament right there. So we're just And you can eye it, you can certainly mark it, or you can send it out to have a computerized radiographic mensuration analysis, either one. So I'm looking at translation with George's line, and then angulation. And of course, you know, some angulation you can see much easier than others, but that's why the computerized radiographic mensuration analysis is really good for angulation and abnormal findings, abnormal movement. And of course, what does that do? It substantiates care is what that does. That's what it does. So let's take another. That's the neutral lateral. Obviously, I'll make any point of reference to what's neutral, but more often or not, it's going to be the motion study. So that's the flexion view right there, and you can see that we have essentially no movement right here. So you have a hypo movement here, and then you can see here you have an increased deflection right here. Actually, you have a little bit of translation going on right here also. So this, see, and if you were not taking motion studies and you were not looking for translation or angulation, you wouldn't find this. So this is very important for establishing the need for care. So I want to make sure that my re-exam is going to include that motion study. I want to take it in the original x-rays to look for ligamentous instability. But in my re-exam, I definitely want to take motion studies to evaluate the dynamics and the kinetics of the spine, not just to establish care, the need for care, but the treatment protocol. Where are you going to treat? So if I know this, I'm going to put a significant emphasis right here with physical medicine in intersegmental movement. Now, this person, in all likelihood, has normal gross range of motion. So if you were only testing gross range of motion, not overpressure, and you were not doing motion studies, you would have just missed two major findings that would substantiate care. And those findings typically are long-term findings. Those are the very last findings to clear up. So anyway, that kind of let's go move past the thoracic. So you see the lumbar spine here. And so we have a structural problem I'm going to make note of. And there was no motion study taken in the lower back area. But in the lower back, I do recommend left and right lateral bending. Remember, when you bend, your spine should move in certain directions. When the low back, it should tilt. It should tilt. So I should see each intervertebral vertebral segment tilting a little bit. There'll be less at the bottom, L5S1, obviously, because it's locked in. But I'm looking for any aberration in that tilting. And remember, it's as simple as getting a CRMA if you're not familiar with it. If you're not familiar with looking at intersegmental motion in the beginning, that's all I would do is get the CRMA test done, computerized radiographic mensuration analysis. And that's what shows intervertebral movement. So the other part of that is not only in coupling and left and right lateral bending, is, in other words, you bend to the right, the spinous intervertebral segments should couple to the right. And also, they should rotate to the right. So I'm looking for rotation also. And remember, in the neck, it goes in the opposite direction. The coupling goes in, if you're left lateral bending, it should be to the left. But the vertebra will go to the opposite direction in the neck. In the low back, it'll go in the same direction. So you will frequently find, especially in the low back, abnormal coupling. And now, this is what range of motion are we talking about? Active range of motion? No. You can have a totally normal active range of motion, but then you'll have abnormal coupling. And so now I have reason to substantiate care with that specific biomarker. And so I could not only have aberrant rotation, but I could have, abnormal coupling, I could have aberrant rotation. Maybe it's stagnant, or maybe it's even gone in the other direction. So that's a huge biomarker that you'll typically miss if you're just not familiar with it. So I'm going to talk about that in just a second. But here are the, as an example of the neck disability indexes. And remember, these are indexes, so they should be performed at every re-exam. And we talked about the importance of when you have these indexes, we talked about the importance of interrogating the patients. Remember, as time goes on, there's three common things that a patient will do to minimize their problem without knowing it. Number one is they'll restrict that behavior pattern. Now, 3 months from now, 2 months from now, 4 weeks from now, a lot of times they won't even remember that they're not, that they've altered a behavior pattern because it's painful or it's uncomfortable. So if you just leave it up to them, they'll forget that they get out of the bed this way instead of, just jumping out of bed like they did before, something like that. And then secondly, is asking about their particular activities, going into detail with their particular activities. Now, here in the Neck Disability Index, you can see it goes into not only just the pain intensity, it goes into the personal care, it goes into lifting, it goes into the reading, it goes into headaches, it goes into concentration, it goes into work, driving, sleeping. See, this is a functional capacity index. This is to be given at every re-exam. And these are quantifying factors to substantiate care. So now, the key with these as time goes on in the first re-exam, second re-exam, third re-exam, the key is not to just hand it to them and say, fill it out. Because remember, I told you they will alter behavior, and they'll also take medications, over-the-counter medications, ibuprofen, Motrin, and they won't think anything about it. So if you'll miss it, in other words, you'll miss that biomarker if you just hand it to them, as opposed to see or interrogate them in each of their, whatever that anatomy is, and then what motion did they do in life that affects that anatomy with overpressure. Typically, overpressure means lifting, putting weight, force on it. And typically, it's not somebody that's going to push on them. So it's typically, lifting or applying, lifting something, or where there's actually weight that's distributed on it. So I'm going to interrogate them specifically and look for restrictions or limitations with pain. And I'm also going to see if they're on the medications, and then they alter their behavior or restrict their behavior patterns with their common activities of daily living and work. That's what I'm going to specifically look for. Those are biomarkers. That's what substantiates the need for care. So that's a classic neck disability index, and of course you got the Rowland low back pain index, and the Oswestry is a little more familiar. It's probably got more brand name recognition, and it's the same thing here. I'm going to go into detail in some of these factors. So those are the indexes, and then remember those are given at each re-exam, and the loss of enjoyment of activities and the duties under duress are permanency indexes. Those are to be given when you're done with care. So these are the factors that will substantiate your need for care. And you've got the pain index there. So let me just finish up on the let me just finish up here on some of these major biomarkers. So let's talk about the major biomarkers to really pay attention to. And what's the importance of biomarkers? Well, the importance of biomarkers are to substantiate care. So in a classic case, we talked about range of motion. We talked about muscle testing, how to do that, which ones to specifically look forward to, range of motion, muscle testing, nerve testing, and then orthopedic tests, and then x-rays, the different static versus dynamic and where you'll find the problem, and then the functional capacity indexes. So that is where you will find, and so typically after the first few days of treatment, or say the first 2 or 3 weeks, the big bioindicators kind of go by the wayside depending on the severity of the injury. But let's say after the first re-exam, the big biomarkers kind of go to the wayside. And what are the core biomarkers that you will be able to substantiate care with? Well, it would be the signs or symptoms of the patient, the frequency, intensity of the patient, number one. In the range of motion, it will be primarily extension with overpressure. That's typically where it'll be. In the muscle testing, a lot of times you won't have anything left in the muscle testing. That's not a good bioindicator after the first re-exam or 30 days. The orthopedic test, we typically said of all the orthopedic tests, the greatest biomarker to substantiate your care is the compression test, the compression. And we said the problem that typically you have is not isolating the joint out properly when you apply the test. And it's either the Kemp's foraminal compression, you heard Kemp's test in the low back. And then I don't want to overlook palpation. I mean, you definitely want to palpate the patient for intersegmental tenderness. And when I palpate, I'm going to go into those joints. I'm not just going to touch the muscle. I'm actually going to apply pressure into each of those joints, whether it's the neck or the low back. And I'm looking to see if there's fixations, but also if there's any pain or tenderness in those joints. That is a common one too. Remember, it's the extreme motions now of bioindicators. Now, another good bioindicator that a lot of people don't use is blood tests, the inflammatory indicators. Those are good bioindicators, and the classic inflammatory indicators are the sedimentation rate. That's a protein degradation. I've found that that's typically, you'll find it a little more positive in the beginning, but it's not as sensitive down the road. The C-reactive protein I found to be one of the single greatest sensitivity tests, C-reactive protein for inflammation. And so that is a very good biomarker. And then your ratio of high to low density lipoprotein, so it's a lipoprotein profile. And all it is, it's the ratio of high to low density lipoproteins, where there's a preponderance of low lipoproteins to high density. Those are inflammatory indicators. So those are the blood tests, but of those three, C-reactive protein would be the blood test of choice, looking for inflammation and documenting inflammation. So not many doctors know about it or do it, or a lot of times we don't do things we don't know. And so the ignorance stops us from doing something. But you will find that that's a very, very sensitive bioindicator. And then the x-rays, we talked about static x-rays are okay, abnormal positioning, but that's not where it's at. It's in the dynamic x-rays. And we're looking at translation and angulation, inflection, extension with the neck, and I like left and right lateral bending in the low back with coupling and rotation. And aberrant movement, aberrant intervertebral movement is a reason to substantiate physical medicine and chiropractic treatment. So those are the most common biomarkers that will substantiate your care, not just for the first 2 weeks, but after the first re-exam. And then the re-exam is done essentially every 30 days for the first 3 re-exams, and then it has to do with the frequency of treatment. So it's every 12 visits or every 30 days. So obviously, if they're spread out, 3 months later, you're not going to do a re-exam. If they're once a week, you're not going to do a re-exam every month, 5 months or 4 months down the road. In that case, it might be every 2 months because of the frequency, or every 3 months because the frequency is so spread out. But in the beginning, I'm going to be doing a re-exam essentially every 30 days for the first 3 months of treatment, because that's typically when they'll be in the active care, 3 times a week, twice a week type of care. And it's the general guidelines are every 12 visits. So if you look at those ratios, 12 visits in the time frame of, they typically happen within 30 days with active care, twice a week or 3 times a week. So that's what you want to be paying a lot of attention to. So that's how you can substantiate the need for care. And remember, you can continue care as long as you got those biomarkers. You can continue care as long as you have them. You do them and you have them. And until you get to MMI. And what's the definition of MMI? Well, the preferred, now remember, this is a guideline. It's not a rule. So the preferred definition is if there's been two re-exam periods, two separate re-exam periods with no improvement subjectively or objectively, and their patient is out of the three phases of healing. And in other words, the body's had a full chance to recover. And during the recovery, in other words, their body's not going to heal anymore. It's permanent. And during two totally separate time periods, and that's what I like to refer to as the minimum. And that's when you're essentially at MMI. Now, can you do MMI earlier than that? Yeah, you can. If I'm gonna say MMI, I would never give MMI in the inflammatory phase of healing for our chiropractic typical kinds of injuries. Would I give MMI in the remodel phase? No, I wouldn't. It just wouldn't make sense with anybody who knows about the inflammatory phases, the three phases of healing. So I'm going to do everything I can not to do that also. And I'll educate my attorneys why they shouldn't be stopping care also and asking for MMI in the repair phase of healing. And then, so it would typically be in the remodel phase, but I'd prefer to have it where there's at least two time periods in the remodel phase, preferably toward the middle, the end of the remodel phase. But definitely two re-exam periods in the remodel phase is typically the very earliest that I would be willing to give an MMI and be able to substantiate that. So that's MMI. So if you have biomarkers that are showing incremental improvement, remember the incremental, they will be incremental. When you're 2, 3, 4 months down the road, you will not see great improvements of ranges of motion increasing 20 degrees. They're going to be very incremental, meaning your testing should be very incremental to find them. If you're doing more gross types of testing, you're not going to find incremental problems. So be highly aware of that. And so those would be the classifications of some of the core categories to substantiate your care. Now that's what will substantiate your care. So it's not only subjective, objectively, but also quantifying it specifically. Now, that's what will give you all the documentation you need to substantiate care and stop this kind of thing from happening right here, which is an IME that stops the care because you didn't have your biomarkers. You just treated the patient, you didn't have your biomarkers, and you didn't report on them in your SOAP notes or your re-exam reports. You didn't report your biomarkers. You're going to get your care cut, and you're not going to be able to do anything about it. Now, how can we stop the services? What services you do from being cut? Well, that has to do with your understanding of the three phases of healing. So what is your objective? So after I found these biomarkers, what's my clinical objective? Okay, well, my clinical objective is going to be based on a few things. Number one, the first thing it's going to be based on are the three phases of healing. Where's the patient at relative to the three phases of healing? Number two is any inhibitory factors with the patient. Are they older? Are they younger? Do they have diabetes? In other words, they have conditions that will limit or restrict their healing. Do they have to work, for financial reasons? And does that work aggravate the problem? That's a very common scenario with personal injury patients. They have to work, and that aggravates the problem. So it's going to be based on the three phases of healing, the aggravating circumstances, and that includes any dormant pre-existing problems, and the therapeutic response to treatment. How is the patient responding to treatment? That's what that's what it's going to be on. So I want to make sure in my SOAP notes and in my re-exams, especially the re-exams, that's really, the re-exams are the macro trends. The SOAP notes are micro trends. So it's the re-exams that really you want to put a lot of attention on. I mean, you have to do both of them to substantiate care and get paid. But the re-exams I want to put a tremendous amount of emphasis on because they're macro trends. I'm seeing the bigger picture instead of slight variations. And so I want to pay a lot of attention to the re-exam. So in the re-exams, on the SOAP notes, I'm going to talk about my goals. So what are my goals? Well, I know the three phases of healing, and we're typically dealing with pain, we're typically dealing with inflammation, we're dealing with range of motion, whether it's active, passive, or joint motion. Whatever findings you did find, whether it was muscle, say my therapeutic goal may be something muscular, if you found some indicators with muscle, but I can give a muscle therapeutic approach, in other words, active therapy, whatever, and the patient have totally no weakness in their muscle. And I can easily substantiate that because let's say they're in the beginning phase of the remodel phase of care. So that totally can substantiate the need, not just because of where the patient's at in their findings, their biomarkers, but knowing where they're at in the three phases of healing is the combination. So that is the key in substantiating your services, is your biomarkers relative to the three phases of healing, relative to the response to treatment. How are they responding at each re-exam? So are you gonna do something else? And a classic case is going from more passive therapies and initially to help with pain and inflammation, to starting some active therapies, at the first, definitely toward the middle of the first re-exam and the repair phase, definitely starting to get into some motion, some active therapies, whether it's chiropractic or therapeutic exercise, and that would be the reason. So here's a kind of a common type of prescription plan of treatment, objectives and outcomes. So this is really basic stuff. You have what you did. Remember, I would have already had the findings, and all this is just saying what I'm trying to do, and what are the categories essentially I'm dealing with. I'm dealing with pain, I'm dealing with range of motion, three types of motion. I'm dealing with muscle strength, I'm dealing with joint related problems, orthopedic. And so those are going to be my most common goals, whether it's increased range of motion, intersegmental range of motion, muscle spasm tension, and that would have been, you'd found that on palpation also. And then what phase? And then, of course, it would be a course of treatment, 3 times a week, twice a week, whatever, defined until the next macro indicator, the next re-exam. So you would have had your biomarkers. Because you found your biomarkers, you put your treatment in place based on the biomarkers, whatever each of those treatments were, and then you would have left it alone until the next re-exam. You would have reported on them in your SOAP notes with every treatment, but that treatment plan would have stayed in place until the next re-exam, and then all of those biomarkers would have been checked again, and you would adjust the course accordingly. Do you need to do more or less, or alter the form of, depending on the response to treatment, but also depending on the phase of care they're in. And that is how I substantiate, and that would be in your notes. So I not only would have had the biomarkers in the notes, but in the plan portion of the treatment of the SOAP notes, especially the re-exam, I would have put in there what the plans were for each of those factors affecting the biomarkers, whether it was pain or inflammation, range of motion, active, passive, or joint motion, muscle strength, joint inflammation or irritation, like with an orthopedic test, or something that may be affecting the ligament, tendon, or cartilage. And so that would have justified. So I had all my biomarkers. I know my 3 ranges of phases healing. Then I'm just going to put my treatment protocol defined by what those biomarkers were relative to the 3 phases of healing. And that's how I would substantiate my care and not have my treatment cut by an IME doctor. And I want to say that, especially in the re-exams, I want to say these things. I want to say what these treatment plans are, and I want to say these things in my re-exams of why I'm doing what I'm doing based on the results that I have, also based on any factors the patient's dealing with, also dealing with the 3 ranges of motion. That's what would determine my plan and the proper therapeutic treatment. That's what substantiates the care and the type of care you do. So you get the treatment you want, as well as you get paid for the treatment you do. See several doctors going to things like this: ICA best practices for types of different conditions, treatment recommendations and all that. Do not do that. These are administrative functions. These are not meant to be doctor functions. They were created by doctors for insurance administrators for payment. So when you see things like this, best practices from the ACA, how many recommended treatments per injury are the Croft guidelines. Do not use those. Why? Because they're administrative functions. And guess what those were based on? They were based on the 3 phases of healing. That's what they were based on, trying to incorporate an injury, also trying to incorporate the patient's condition, everything we just talked about. So as a physician, you're supposed to be the one to understand the patient's injury with their biomarkers. You're supposed to be the one to understand the 3 phases of healing and any restrictions or limitations that that particular patient may have in their response to treatment. That's your duty as a physician. That's what you should know how to do. And so when you base your treatment and your therapeutic protocol on those factors, you'll never go wrong. That is why I never lost a case in court, because that's exactly when I went in and talked to the jury, I didn't bring up Croft guidelines. I talked about the patient. I talked about what I found on the patient, the biomarkers. I explained the 3 phases of healing. I explained my treatment protocol and what it was based on how the patient was responding, their biomarkers, and the 3 phases of healing. And then I included any restrictions or limitations with pre-existing problems or work or health-related issues or age. And that's how I completely documented and substantiated every case and never lost in court. And if I couldn't do that, I would tell the attorney, don't go to court. Settle out of court. But your whole treatment protocol should be based on that. So do not use, Croft guidelines. Do not use the ICA best practices, ACA best practice. Those are administrative guidelines. And I'm very easily, if I'm any kind of savvy attorney, I'm very easily going to go in there and help destroy you, because it's never about an administrative function. It's always about the patient. You don't base your care on an administrative book. Your care is based upon the patient and the findings of the patient, the facts that we just discussed. So I will very easily be able to, even though it says, as an example, let's say the Croft guidelines say 60 treatments, but you don't have the biomarkers, I'm very easily going to destroy Croft guidelines relative to your biomarkers. Now, just the opposite occurs also. If I have the biomarkers, but say they bring some other guidelines in that says it should be less than that, I'm still going to be able to destroy them, because I've got the patient, I've got the biomarkers, I've got my reasoning behind my treatment protocol of what I'm trying to affect with the biomarkers, muscle spasm, pain, range of motion, restrictions, etc., as well as the science of the 3 phases of healing. So I will always win that argument there also. So that's why, and the only reason I'm pointing that out is I'm surprised how many doctors come to me and start talking about these guidelines. I'm like, no, those were meant for lay people. They weren't meant for doctors. They were meant for lay administrators to interpret the biomarkers, the 3 phases of healing, the response to treatment, and limitations or restrictions for payment. That's what those were.